Some of them are very scary. So we need to know. But it's not written there. I've never seen this written anywhere. And I'm not sure what that is. Okay, so we're good?
Yeah. Sorry about that. We're a little technical difficulties here. So I'll just skip it. Okay, so this 83-year-old male, diabetic, comes in, no problems. I look at him. He's got a 0.6 cupping. Oh, that's weird. Do an OCT. He's got some thinning on the left. Right eye is good. No symptoms, nothing. We do a visual field. Bingo. Superior obgerum, inferior obgerum, nasal step here, nasal step there. He's a low tensional glaucoma, one eye. We treat him out of the blue at 83 years old. 72-year-old male, again, a diabetic, comes here. We got to talk to people, right? So he's a 0.5, 0.4, nothing too complicated. But he tells me, Doc, I've got some trouble parking on my right side. Okay, that's weird. Yeah, we do the OCT, it's normal. So let's do a visual field. Bingo. This is an incongruous quadrantenopia. Okay. And so I put him, I think that patient had a stroke on his left LGN or somewhere around there. We've had asked for a CT. It's been 6 weeks. We're still waiting on it, so I have no idea. But he probably has had a stroke a while ago, and so kind of an interesting case. Number 7, 64-year-old patient, kind of a bit of everything. She's got glaucoma, she's got diabetes, and she's got cataract on the left eye. Look at the OCT, some thinning on the left, much bigger cupping here than you do on the right side. This is the field that we got. So you got some constriction, which could be cataract, which could be glaucoma. And what's the central part? That lady is getting injections, by the way, okay? This is macular edema, I think. And the glaucoma is possibly because of she's getting injections, and that there's a big link between glaucoma and retina work. Or if we do cataract surgery, some of that field might get better. Of course, not the central part. So this other case is interesting. 52-year-old male. He's well, not really. He's got glaucoma. His pictures are 30 and 25. He's amblyopic in his left eye, but this is OCT. Oops, sorry. So you see that doesn't look cupped, but he's got some, thinning, and this is his visual field. He has a staphyloma. Okay, so this is why he's amblyopic. This has nothing to do with the pressure. We're still treating him, obviously, but this is not a glaucoma visual field loss. Next case is a 67-year-old male. He's got cerebral ataxia with, I kind of forgot what it was. He comes in for decreased vision in his right eye. This is OCT. So you can see he's got a lot of thinning here, and look at the edema. He's got K2 is here on his optic nerve. So he's got optic nerve edema, and it's actually even getting close to his macula. We do a visual field. We get this. This is an altitudinal defect, typical of an AION. But what does he have edema in his left eye? So I'm thinking, is that an asymmetrical papillary edema? Is that related to his ataxia? I didn't see the link, so I called a neurologist. We talked many times. We redid an MRI. It was normal. We even did a lumbar puncture, normal. I sent him to neuro-ophthalmology, and they kind of agreed with me. This is a sequential NAION. So I saw him. He already had his NAION. Now he's in the atrophic stage, and he was getting his NAION on his left eye, and now he's got atrophy, so he's getting the same thing as his right eye. There's nothing we could do for him, unfortunately. Not very lucky. So this is a 83-year-old lady with macular degeneration. So this is a central loss, typical of macular degeneration, and the optic nerve OCT is normal. This is a sad case here. It's a lady, she's 70-year-old. She's got rheumatoid arthritis. She's been on Plaquenil for years, if not decades. About 3 years ago, she's an Abbotsford patient. 3 years ago, Dr. Chu found Plaquenil toxicity, told her, lady, you got to stop this stuff. It's harming you. And that's it, right? So we move on. And then she comes back a couple of years later, and she's still on the Plaquenil. So apparently the Plaquenil was making her feel so good that she had hell with it. I'm going to cut. So she switched rheumatologist, didn't tell him that she had toxicity. That guy didn't bother asking for a record. So he gave her Plaquenil. And you can see how thin the macula is over here. I can't see the numbers, but they're very thin, okay? This was the original, this is typical Plaquenil toxicity. Do not miss that. I've seen many over the last 30 years, but this is an obvious one. So this was the first one we did. Should be good. So this is his field loss on his good eye. He had a inferior, it looks like almost like an arcuate. And with time, it got better. But that's his good eye, the right eye. Next case, 48-year-old male, again, diabetic, 2030, 2020. And so we do, CT is normal. We do a visual field. I think that's Dr. Tokar who's in the visual field. That's what we usually do. And we find this. That looks, it's like almost like an arciform type of thing. And I question a little bit better. He's got heart issues. So I think this is a BRAO. And I think he had AFib, a little stroke, because it's nasal. We didn't really notice it. But that's why he's 2030 and 2020. This is not a glaucoma case. This is thin on both sides. This is the left eye, which is the worst eye. This is a typical this is a secocentral visual field loss. And this is an inferior paracentral scotoma. So this is a severe glaucoma. Severe means visual field loss superior and inferior. This guy, in glaucoma eval, 0.45, 0.3 cupping, no cataracts. OCT doesn't look bad. We do this. Does that bother you? It doesn't bother me. Okay. This is the lens rim artifact. Don't send these patients. There's no cupping. That 0.45 does not give a feeling. That's pretty obvious. So this is not a normal OCT. We did a visual field. Again, same thing. Binasal, there's not that many things out there that give you binasal. This is an artifact. So this is an end-stage glaucoma. NFL is 35 and 45. That's pretty darn thin. And this is the field. It's all, so this is end-stage glaucoma. Next case, lady that was referred, it's kind of weird. She was referred by one of you guys for a visual field defect, but she ended up being an RLE. So somehow it gets misplaced. But so anyway, so this is what she has. So of course, wait a second, let's wait before we do an RLE. So what is this? This is a quadrantanopia, upper left quadrantanopia. And what's this? Macular sparing, guys. This is a right cortical or occipital lesion. I go back, I called, apparently she had seen Dr. Duncan Anderson 2010, 2 weeks before she saw him, visual field loss, peripheral field loss, 2 weeks before, got better. And so the visual field is the same as it was 10 years ago. So she got used to it, but was it a migraine or a stroke? That's one or the other. But she lived on, and we're still going to go ahead with doing the RLE, but at least I know, but it's not something that's ongoing. This patient, this is a bitemporal amyotropia here and here. And of course, there's more to it, but this guy had pituitary tumor surgery in 2017. So obviously the lesion was so big, got missed, obviously. He's gone, this is gone, and part of the optic nerve was involved there. So he's blind in that eye. Luckily, if you want to call it lucky, he's amniotic in that eye. So that got found way too late. This is another case of artifacts, lens rim artifacts, very obvious. It's normal in the other eye. He was sent for large cup disc in 0.5, 0.4. No. Now, that being said, he does have a bigger, a deeper cup here than this, so we're going to follow him. And there's some thinning here. So, I'm not saying he doesn't have glaucoma, but this doesn't work. Last case. 51-year-old patient, glaucoma patient, 35 pressures on the left eye. This is a field, and it's been like this since 2007. Trouble is, her cupping is 0.4 on the right and 0.8 to 0.9 on the left. Okay. Color blind. I'd seen, so I was wondering that she had seen retina and maybe a neuroophthalmologist, so I tried and get the records. The retina had done an ERG, which was normal, and she had been sent to neuroophthalmology, who diagnosed a nutritional optic neuropathy. Okay, never seen one. That's kind of nice. Okay, I'm sorry. So, but I do a little bit, I've never seen one, so I said, okay, well, I don't necessarily trust what I see. I kind of have to make up my own mind. And come to find out, and her central vision is gone. The nutritional optic neuropathy affects the central vision. You have a central scotoma or sequocentral. This is not what you have. Decreased vision, 2200, optic atrophy, color, so this doesn't look like that at all. And you can see, well, maybe it's a 0.8, 0.9, but 7 years ago, she didn't have a 0.8, 0.9 cupping on the left eye. I think this is functional. I really do. Okay, but she still has glaucoma. You know what functional is, right? Little quiz. What do you guys think this is? This is a scotoma here. What kind of scotoma? Say it? Correct. Is there anything else?
Starting of the arcuate.
Absolutely. And you can see it here on the pattern deviation. So this is a glaucoma patient. Very good. How about here? So this is the optic nerve, the blind spot. So this is the scotoma. What kind of scotoma is this?
Sorry for other people on the other side to hear.
Don't make me do that, please.
if you could repeat it, then, so they can hear it on the other side as well, that'd be great.
Okay, sorry. So this is another type of loss. This is a paracentral loss. Okay, paracentral is within 10 degrees. 10 degrees is here. So it's within 10 degrees. This is the glaucoma visual field loss. Okay. How about here? It's pretty easy.
Right side involvement.
Left homonymous amyotropia. So right hemispheric lesion. And it's very congruous. So it's more posterior. The more posterior, the more congruous it is.
This ended up being an arteriovenous malformation on the right side. Interesting case here. What do you guys see on the first two visual fields, right eye, left eye? What is this? Absolutely. Okay, and then maybe a little scotoma here. Okay. How about here? It's an arciform, right? Very obvious arciform, sugar inferior. And then a few months later, boom, this and this. What's going on? Glaucoma got worse in a few months.
Left pituitary.
This is a quadrantenopia.
So it's
Kind of
left.
incongruous, so more anterior. So that patient had a stroke on her left side, on top of the glaucoma. Nothing to do with glaucoma. So don't freak out. Send them to me, but it's pretty interesting. So other things can happen besides the original disease, right? This is EPDs. This could be a lot of things. It could be cataracts. It could be media opacity of sort. But this is really a lens rim artifact as well. So no worries. And again, if it's you'll see if there's a cataract. You'll see if there's any cupping. So if it doesn't match, it's a lens rim artifact. If we do it. That's about it, right? This is central. So what can it be? Central usually lasts too long. Yeah, this glaucoma is really not. This is macular degeneration. Okay. Pretty bad one, I would tell you. The other case wasn't as bad as this one. This is a glaucoma patient. Doesn't have much. It's not the best of tests, but there's some deficits here. Then a few months later, poof, we get this. So there's some, so it looks like an arcuate, some constriction, so seems like the glaucoma gets worse. Patient has a cataract. So what do we do? They do cataract surgery, right? Then we do another visual field. Much better. So all this, but much of that constriction was cataract, but there's still an arciform there, yeah, for sure. So you can argue it probably got a little worse here, but so the cataract was what made the visual field worse. This is not a great picture, but what is this? The normal optic nerve? What is it? No. Not this way. This is something. So you don't see the contour at all. And this is red, it's bright pink, and this is papilledema. Now the problem is, they've got an arciform defect. This looks like glaucoma, right, on both sides. Papilledema takes years, if not decades, to get this. So this is likely a young, obese female with IIH, who got misdiagnosed. Now she got field defects, which may or may not get better, and she needs to be treated ASAP. One of the few last cases. Scotoma here. So what do you guys see? It's not as obvious, but there's some edema, not as obvious as the other case. There's edema on both sides, more on the right side. There's some tortuous vessels and some telangiectasias here. This is a Leber's optic atrophy, and typically young males, and they got central or pseudo-central field loss. And the vision tends to be 20/200. Usually both eyes are affected. It's not something we see very common. So this is the last case. So what is this? Does that look neurological? And it's both eyes. It looks like it's a bitemporal myopia. Is it a bitemporal myopia? So what's important? Look at the median here. Does it respect the median? It crosses. This is not a bitemporal myopia. This is not pituitary tumor. This is an optic nerve problem. Both sides. It's not a neurological problem. I told you this patient's got thyroid issues. Help? It's compressive optic neuropathy. Thyroid disease. Okay. They're not common. They didn't work. So we do a visual field yearly on these thyroid issues. So this concludes my talk. Any questions? Yes.
What does functional mean?
Well, it could be hysterical convergent syndrome, malingering. So it's fake visual field. So secondary gains, whatever. So again, that patient has glaucoma, but the visual field is focused, completely focused, or at least part of it is focused. But nobody's found it. So next discussion with her is going to be a tough one. Again, because I didn't really believe and I looked it up, and that's not what it. And it's rare here. People that would have that type of neuropathy, the alcoholics who don't eat well. Usually it's a folate or e-complex problems with, or if you're in Africa, you're starving. We don't starve, in North America usually, and usually it gets better with treatment and proper food. And so that one, it's been like that. It hasn't changed. Again, there's central vision is good. Color vision has nothing to do with it. So a whole bunch of things that don't match. That fortunately they're not so much. I don't think realize, but I don't buy that. Any other questions? Okay, thank you very much.
Not about. Oh, let me check here.
Dinner time.
Dinner time, yes.
And small groups.
Do you have any questions on the Abbotsford side?
Oh, yeah. So I was forgetting about that. Sorry.
Ask. Anybody have questions for Dr. Payne from Abbotsford? No, I think everybody's just hungry.
Okay.
Okay, let's have dinner.
Yeah.
So what we're going to try to do is do small groups. So we're going to try to do, okay, you guys are in good hands. Follow Manpreet, okay?